Of the heart. The electrical activity of the heart is primarily originating from the SA node. So if this is the left right atria and this is the left atria and we have the septum. So the SA node is located somewhere over here. Now this SA node is essentially a very small strip of specialized cardiac muscle. All the conductive fibers of the heart which are carrying the electrical potential are essentially specialized cardiac muscles. So this SA node is a 3 into 15 millimeters small strip located on the posterior basal part of the right atria. From SA node, this impulse moves from the SA node towards the AV node. Now to reach this AV node, the impulse can take either of the three tracts. Now these tracts are anterior tract, middle tract and the posterior tract. The middle tract is also called as Venke back tract and this posterior tract is also called as the thoral tract. Now these are the specialized cardiac muscles which are conducting the electrical activity generated at the SA node pacemaker towards the AV node. There is another fourth tract which is interatrial and which carries the electrical impulse from the right atria to the left atria, and that is called as the Bachmann's tract. Now these are essentially meant for spreading the SA node activity from one place to the other. In the AV node there happens a delay, and this delay is essentially because of the decreased number of gap junctions. So this is the AV node and there is a AV delay. This AV delay, the reason for the AV delay is decreased gap junctions over there. We may also note over here that the SA node is derived from the right side of embryonic structures. Right side embryonic structures give rise to the SA node, and the left side embryonic structures they give rise to the AV node. So this also brings the point that the SA node is supplied by the right vagus and the AV node is supplied by the left vagus. And similarly for the sympathetic tracts, the right side sympathetic tracts and the left side sympathetic tracts are supplying these areas. The AV node as such creates a delay in the conduction of the impulse from the atria to the ventricle. AV node, the delay is basically of 0.13 second, and the total time that it takes from the SA node to the end of the depolarization wave to reach the ends of the ventricle is 0.22 seconds. So we see that about 50% of the entire conduction delay happens primarily in the AV node, and this is essentially a safety factor where the impulse from the atria are prevented from moving into the ventricle just like that. So it keeps a check of so that when the atria is contracting, the ventricles are relaxing and vice versa. Otherwise, if the depolarization would take place across atria and ventricle together, then the entire contraction would take place and no pumping would have occurred. So this is a nature's method of synchronizing the thing. From the AV node, this bundle of his divides into the left and the right side, and this on the left side this further divides into the anterior fascicle and the posterior fascicle. And this anterior fascicle, when the if a block on the anterior fascicle is likely to cause a left axis deviation, and a block in the posterior fascicle is likely to cause the right axis deviation. So this is the conduction of the ventricles. This further the conduction impulse spreads along the endocardium of the ventricle, and then from the endocardium it spreads to the epicardium. So the spread is from the endocardium to the epicardium, endocardium to epicardium, or last part of heart to depolarize. Now we see the effect of sympathetic and parasympathetic system on the conduction in heart. The parasympathetic system is by vagus nerve, and this is secreting acetylcholine. Now this acetylcholine acts on M2 muscarinic receptor. So it acts muscarinic receptor M2. In the M2 muscarinic receptor, it causes the decrease in cyclic AMP, and with this decrease in the cyclic AMP, the potassium channels they open up, and this potassium efflux takes place. This leads to hyperpolarization. Hyperpolarization prevents the impulse movement, and the cell is not ready to depolarize well, because it is now more depolarized. If the cell was say in a minus 90, now because of hyperpolarization it is now minus 95 or minus 100. So it will be more difficult to depolarize it, and in this way the conduction delay takes place, and in this way the contractile delay also, the decrease in contractility also takes place. The sympathetic system, adrenaline and noradrenaline. Now this noradrenaline, which is secreted from the sympathetic nerves, which are being supplied by the into the heart, the stellate ganglia. The sympathetic nerve to the heart comes from stellate ganglia, and the postsynaptic neurons, they are secreting noradrenaline, and this noradrenaline is acting on the beta 1 receptor, and in the beta 1 receptor it is causing increase in the cyclic AMP, and with the increase in the cyclic AMP, the calcium currents would increase, and because of the increase in the calcium current, there would be more calcium coming into the system, so that the calcium would be coming in, and similarly there would be more sodium into the system. So because of this, there would be depolarization, and this is going to lead to increase in the sodium levels, and the increase in the sodium levels is going to cause more current formation, more depolarization, and this is going to increase the rate of the heart. This is going to increase the heart rate. Because of the calcium ions, there would be increase in the contractility. Now at the same time, because of increase in the depolarization, there would be increase in the conduction. This increase in the heart rate over here, this is known as the chronotropic effect of noradrenaline. The increase in the conduction is known as the dromotropic effect of noradrenaline, and the contractility is known as inotropic effect of noradrenaline. that is the sympathetic. And lastly, there is one more effect over here, and that is known as the bathymotropic bathymotropic effect. Bathymotropic effect essentially means excitability. So this is primarily at the SA node, where the sympathetic systems, for the noradrenaline, you have actions, that is increase in the chronotropic effect, increase in the dromotropic effect, increase in the inotropic effect. Now we come to the action potentials in the heart. Now heart has basically two types of action potentials. So if we talk of action potential, one action potential is that of the excitable tissue, that is namely the SA node, and the other action potential is that of the ventricular muscles. These ventricular muscles are leading to the contraction. If we talk of the ventricular muscle, in the ventricular muscle, the action potential is a plateau potential. So it is the classic plateau potential is occurring over here, where what is happening is that these are at minus 90 millivolts. As compared to the SA node, the resting membrane potential is minus 60 millivolt. So in ventricular muscle, what is happening is at minus 90 millivolt, there is a sudden depolarization wave because of the fast sodium channels. There is a rapid depolarization wave, and from this rapid depolarization wave increases the sodium conduction. So this depolarization, also known as the phase 0, is basically a sodium event, and that is because of the fast sodium channel. And then the conduction of this fast sodium channel decreases, leading to a small dip. This is also the same time where the potassium channels are slowly opening and small efflux is taking place in the potassium channels. Now this is the time where the sodium conduction is taking place. Now over here, slow potassium efflux is taking place, but calcium influx is happening rapidly down here, and because of that they tend to cancel out each other, and there we get a plateau potential. So this comes to the phase 0. After that we have the phase 1. The small dip is known as the phase 1, and then because of the calcium efflux, the plateau phase is there, which is the phase 2, and thereafter this rapidly drops down, and this is the phase 3, and this rapid drop is because of rapid potassium efflux, and this continues to go beyond this, and then it recovers, and this recovery part is the phase 4, where it is hyperpolarization. This part is the hyperpolarization. So what we see over here is that the phase 0 is a sodium event, while the phase 1 is because of the stoppage of the sodium conductance and a slight potassium efflux. And then the phase 2 comes, where the calcium channels have opened up. Now these calcium channels are L-type calcium channels, and L-type calcium channels, they open up and they play a major role for the plateau potential. And as the progress occurs, the more and more potassium channels are opening out, and because of the rapid efflux of the potassium channels, the action potential drops further, and it overshoots into the hyperpolarization. This entire part is the refractory period. Most of the part is the refractory period. Only a small, everything is a absolute refractory period, with whatever is being shown over here in the yellow. A very small part, only this much part is the relative refractory period. Otherwise you have entire part from here till here. So everything from here till here, everything is the absolute refractory period. Now compare this to the SA node. What is happening in the SA node? What is happening now? SA node is in a minus 60 millivolt resting membrane potential. It is not having, it does not have, there is no fast sodium channels over here. So there is, therefore there is no phase 0 in the in this part. So this phase 0 is absent over there. So it, the in the minus 60 millivolt, from at the minus 60 millivolt, there are leaky sodium channels over here which continuously leak into this into the cell, and they create a current which is also known as funny current. So this, the reason for this funny current is, there are three reasons for this funny current. The one prime reason for this funny current is HCN channels. Now HCN channels are monocationic channels which are essentially leaking some sodium into the system. So basically what we have are small sodium leakage. These are different from the fast channels. And these are, there is a very small leakage of sodium occurring into this, and these get activated whenever the hyperpolarization has been achieved. So whenever there is a hyperpolarization beyond minus 60 millivolt, the HCN hyperpolarization activated channels get into action, and they are causing leaking of the sodium channels. There is also small calcium leakage also taking place. So there is a small calcium influx over here, and these calcium are different from that. These calcium channels are transient calcium channels, so referred as C8 calcium T. So these are calcium T channels. T stands for transient channel. Please mind it, over here it was the L channel. Over here, if we see over here, it was the L type of calcium channel, but here what you see is the T type of calcium channel. The L type of calcium channels were long-term calcium channels. These are T are the transient calcium channels, and these calcium channels are causing these sodium and small sodium and calcium channels are causing continuous leak into the membrane, and this is creating what is known as the funny current, denoted by this IF. And when this potential reaches about minus 40 millivolt, when this potential has reached minus 40 millivolt, there is a rather faster shoot of this depolarization, and this is now because of calcium L channel, L type of calcium channel. So the L type of calcium channel influx takes place, and because of that the depolarization wave starts. So this was what is equivalent to the phase 4 on the right side of the diagram, and this is what is equivalent to the phase 0. Because of the potassium channels opening up, this again the repolarization takes place. Because of the potassium efflux, this deep action potential drops back towards minus 60 to the extent of getting repolarized beyond minus 60, and in the minus, and after when it gets hyperpolarized beyond minus 60, then again the HCN channel kicks into action and the funny current starts. So what we see as a difference between the two types of action potential, ventricular action potential and the SA node action potential. The SA node action potential are resting membrane potential itself is minus 60 millivolt, and there are no typical fast sodium channels over there. There are leaky sodium channels over there. There are HCN hyperpolarization activated channels over there which are causing leaking sodium into the cell. There is a calcium T channels which are causing the entry of this calcium into the cell, and because of this phase 4 is in action, and then the depolarization is basically a calcium event. So please note over here that in this the depolarization is a calcium L event, and over here the depolarization is a sodium event. So the depolarization of the SA node action potential is a calcium event, while the depolarization of a ventricular muscle action potential is a sodium event. And here, then after the phase 0, you directly come to the phase 4 over here. So there is a drug which is causing blocking of this funny channel, that is the HCN channel. So ivabradine blocks the HCN and thus causes the block in the funny current, and that is how it decreases the heart rate. So we can remember this like this: funny current ivabradine acts on funny current, causes bradycardia, and it acts on sodium channels. So ivabradine is a drug which is used in the treatment of systolic heart failure, where just want the heart rate to decrease. An alternative to beta blockers, the ivabradine is used as a drug. Drug like ivabradine can cause bradycardia by blocking the funny current and the sodium channel, that is through the HCN. Similarly, there are drugs like lignocaine which can block fast sodium channel. Class 1 antiarrhythmic drugs like lignocaine are capable of preventing the depolarization by blocking the sodium channel, and these are class 1 antiarrhythmic drug. Similarly, you would note that lignocaine is also used as a local anesthesia in neurons, where it has a membrane stabilizing property by preventing depolarization by blocking the fast sodium channels over there in the neurons, and thus they are capable of preventing pain in the neurons by acting as anesthesia. Similarly, drugs which act on potassium channels. So drug which act on potassium channels, these are the class 3 drugs acting on the cardiovascular system. The class 3 drug mainly basically amiodarone. Amiodarone acts on the potassium channels. So amiodarone can prolong the potassium channels. They can block the potassium channel and they can lead to long QT. Similarly, drugs which act on the calcium L-type calcium channels. Now these are the calcium channel blockers. Namely, you have nifedipine. So these constitute the class 4 drugs of the acting on the cardiovascular system, and this constitutes the class 3 drugs which act on the potassium channels, and these constitute the class 1 drug which act on the sodium channels. Now the class 2 drugs are the beta blockers. Now if you remember the sympathetic system is basically increasing the cyclic AMP and thus increasing the sodium, calcium, and therefore causing depolarization. Thus this leads to increase in the conduction, and this leads to the increase in the heart rate, increase in the contractility. Now if this gets blocked, so there would be, when this gets blocked, entire pathway will be blocked, so there would be decrease in the conduction, decrease in the heart rate. With the noradrenaline and the sympathetic system activity, the funny currents become faster, the heart rate becomes quicker. As you would see in the green line, the peak is achieved in a shorter duration of time, so the heart rate is therefore getting increased. Therefore, with beta blocker, the opposite of this would happen. The heart rate would become shorter, and in the ventricular muscles, the contractility will decrease. With parasympathetic system, the acetylcholine has decreased the cyclic AMP, and therefore the decrease in the sodium and calcium availability. As with the green line, we can see the funny current becomes prolonged, therefore the heart rate has become slower, and there is more time is required to achieve the peak.